Good afternoon. As you'll know, I'm Courtney, and this is my presentation on hepatitis C infections among young injection drug users. My project focus was in the area of my practice setting, which is here in Anne Arundel County at Anne Arundel Medical Center. This project is for the class I'm currently taking, which is the role of the nurse leader in population health. And the goal of the project was to identify a vulnerable population and choose a problem within that population to work on. Additionally, I was tasked with finding interventions to help improve the problem, along with how to measure my successes once I implemented interventions. So here we go. Okay, so the first slide is about identifying the risk population. And hepatitis C is historically known as a baby boomer's disease. The reason being is because people born between 1945 and 1965 were overly susceptible to the disease due to a lack of screening for bloodborne pathogens prior to 1992. The majority of exposures and transmission during this time period for this age group are believed to have happened throughout the 80s. Transmissions virtually actually disappeared in 1992 and after when rigorous screening protocols for blood and blood products were put into place. This population, 1 in 33 baby boomers are actually estimated to be infected with the hepatitis C virus. And baby boomers also account for about 75% of today's adult chronic infections. The CDC and other agencies worked very hard over the last 2 decades to decrease hepatitis C transmissions and have had considerable successes. That being said, a new wave of hepatitis C infections has been trending along with the increase in injection drug users and heroin activity across the country over the last 5 to 10 years. Drug involvement is the most prevalent way these new transmissions are occurring. However, people getting tattoos, body piercings, practicing unsafe sex are also at risk. However, there are occurrences of medical errors leading to transmission, but those incidences are very rare and extremely low. Hepatitis C infections are growing most rapidly in the white under 30 population. These individuals either have a history of drug use or are current users. Maryland, as an interesting fact, are particularly at risk as Maryland has a disproportionate number of heroin users as compared to other states. So here are some additional demographics that place my community at risk for hepatitis C infections. Anne Arundel County is predominantly white, as 75% of its residents classify as white, non-Hispanic. And in the most recent census, 19.7% of the population was actually under the age of 30, and that happens to be my target population for this project. Anne Arundel County is made up of mostly suburban and rural areas, which is where statistics show have the highest rate of injection drug use and hepatitis C transmissions. The majority of hepatitis cases are linked to the practice of sharing needles and drug preparation equipment. And being that Anne Arundel has a disproportionate, or not Anne Arundel, but the state of Maryland has a disproportionate number of heroin users, that all kind of links together. And as you can see in this graph I've provided here, the CDC shows that the rates of hepatitis C have decreased significantly since 2000 in the age groups from 40 to about 60 years old. However, you can see it rise again between 2006 and 2007 in the non-baby boomer age group, which is basically the 39 to 20 age group. Hepatitis C infections are estimated to be underreported in the US by about 13.9%. The reason being is that 70 to 80% of acute cases are asymptomatic until late stages, or they have the onset of symptoms. Also contributing to the underreporting is the fact that about 15 to 25% of infected individuals will actually resolve without treatment, having never known they were even infected. In 2015, new cases were estimated to be around 34,000 nationally, which is approximately 14,000 more cases than were reported in 2011. So a pretty big jump there. In 2016, the Anne Arundel County report reported that 652 cases were in Anne Arundel County, but that included both acute and chronic cases, which was an actual increase of 133 cases from the previous year in 2015. So it is growing in Anne Arundel County. In the US, 30 states reported an increase in cases of more than 200% between the years 2010 and 2014. And all states noted that the largest increase in cases was to be among young persons residing in non-urban and suburban areas or counties. Some possibilities that play into why this epidemic has progressed the way it has and can be contributed to the low primary care provider to population ratio. The ratio in Anne Arundel County is actually worse than that of the state average in Maryland. This ratio contributes to the fact that 17% of residents currently have no primary care provider. Additionally, with such a low ratio, it makes it very difficult for residents to find a provider at all. Even those who do have one suffer long wait times or a long time waiting to get into their doctors because the providers are actually overwhelmed. Furthering this problem, about 6.4% of Anne Arundel County residents are uninsured. When people lack health insurance, they tend not to seek regular care or treatment as it can be costly to themselves. A locally published statistic states that 11.9% of Anne Arundel residents couldn't even afford to see a primary care provider even if they had accessibility to one. Individuals not being seen regularly also do not receive preventative care or education, which can lead to the formation of chronic illness or injury and even further spread disease as people aren't being treated appropriately or getting the education they need on how to prevent transmissions to others. These are some local statistics that also contribute to what makes Anne Arundel County residents vulnerable to the hepatitis C virus. Anne Arundel County's 2016 report showed that 26% of children living in Anne Arundel County actually come from single-parent families or single-parent homes. And 3.8% of families live below the poverty line, with 5.9% of individuals living below the poverty line. And studies do show that areas with high violent rates or crimes actually correlate to drug problems in those areas. And in Anne Arundel County, the violent crimes were 460 per 100,000 people in 2016, whereas the state of Maryland, which is still pretty high, at 465 per 100,000, whereas the U.S. average is actually 373 to 100,000. So the state of Maryland and Anne Arundel County are both very high in terms of violent crimes, which has, like I said, been correlated with drug use and drug problems. Various studies have been shown showing children stemming from single-parent family homes are at greater risk for truancy, school discipline problems, arrests, antisocial peer pressure, premature sexual behaviors, and also substance abuse. And that came from a study I read by Lerner and Johannessen. The next few slides outline some of the interventions I have proposed to decrease the hepatitis C transmission rate here in Anne Arundel County. The first program is the introduction of a needle exchange program, and statistics show that nearly 43% of injection drug users share needles and drug manufacturing equipment between them. And according to the CDC, the one-time use of syringes still remains the most effective way to limit transmission of disease from person to person. By limiting such behaviors and exposures, research has also shown that 25% of hepatitis C seroconversions could have potentially been prevented by eliminating those behaviors. And in a study done in the UK, actually, a needle exchange program combined with other assistive programs potentially decreased the odds of new infections by up to 80%. So these needle exchange programs can have a pretty profound effect on communities where drug prevalence is there. The foundation of a community needle exchange program would provide access to sterile needles and other one-time use equipment. A study done by the National Institute of Health actually found that there was a reduction by 80% in risk behaviors when a needle exchange program was being utilized within a community. The program would also provide referrals to substance abuse programs, as participants who attend these programs are 5 times more likely to enter drug treatment programs than those who are not participating. HIV and viral hepatitis counseling and testing would also be provided by this program, as screening and testing are very important, and 25% of people infected with HIV will also test positive for hepatitis C. Education, as with any issue, is crucial here, and an education program would include helping drug users identify what their risk factors are, how they can prevent the disease from spreading or contracting it, and also provide what their available treatment options are should they want to partake in a treatment program. As part of education, there would be peer-to-peer groups so that those in the program can help new members. Also, it provides a platform for members to provide and share their own experiences in order to help others get clean or be more safe within the community. The program would have to work in many ways in order to actively penetrate the community here in Anne Arundel County. There would be an establishment of school education and anti-drug programs with the intent of capturing the young audience early before drug introduction happens. There would also be parent education available, which would teach parents risk factors for their children and some early interventions as well as prevention for their children. Additionally, holding pop-up information sites at various community locations and times to provide information and awareness throughout the community would be helpful. These pop-up locations would happen at churches, schools, outside grocery stores and shopping centers, as well as community events. Lastly here, establishing a clinic with a corresponding mobile unit that goes out into the community would be part of our programs. A mobile unit would bring information and resources to those who may not have the means to travel to a clinic site and be seen. Both the clinic and mobile units would provide screening and testing for blood-borne diseases to the willing community members. If someone tested positive, treatment and follow-up examinations would be offered and provided to them. It would also allow a platform for monitoring the community and helping with their seroconversions. In order to track program progress, participating individuals would need to be tested at regular intervals, which would allow the tracking of new cases from chronic cases and also allow us to monitor seroconversions within the community. A positive outcome for this would be a seroconversion decrease over 4 quarters. Additionally, patrons who frequent the needle exchange program would be surveyed to monitor their behavioral changes regarding needle safety and equipment practices after they'd been educated. The survey would also assess their knowledge of risk behaviors and how to prevent infection based on the education that they received. For this project, a short-term goal would be to decrease seroconversions by 10% within the first year. And then a long-term goal would be to decrease seroconversions by 30% within 5 years. So the last bit of this project was to state how I will promote positive social change within my community as a scholarly practitioner. And the way I look at this is that I have two communities. I have my hospital-based community and I have my residential community. So within my hospital community, I can continue to encourage others to participate in physical activities like mud runs, races, group hikes, like we already do. We do, as a team, often engage in these activities and get a bunch of people together all at one time. And what these activities do are great for team building and boosting morale, in addition to promoting a healthy lifestyle. In my residential community, I can continue to volunteer or work at local blood drives, as well as donate blood myself as often as possible, as the local hospitals are always in need of blood. Additionally, there's a special program called Dare to Care, which the physicians I currently work with on the vascular team actually designed. This program is not just national or local, I'm sorry, but it's national and international. What this program does is it offers a few free community screening to residents for heart and vascular diseases, and it generally finds things that people wouldn't normally know they would have until it's been a catastrophic event. So things like an abdominal aortic aneurysm. So we find those things before they rupture, and then the intervention can happen earlier, and these people live healthier, happier lives as a result. Additionally, as Maryland has one of the highest rates of cancer in the whole country, I can participate in the annual breast cancer awareness drive and survivor luncheon and promote awareness to breast health for these individuals, as well as I can support the local leukemia and lymphoma societies as they run an annual campaign every year to raise awareness and funding for research within our community. So that concludes my presentation today. Thanks for listening.